Greetings everyone. I want to welcome you to the first workshop session of the 2021 Chisholm 83rd Annual Gathering. I'm Paula Barker, and I'm Senior Executive Assistant for Events and Administration for Chisholm, the Council for Health and Human Service Ministries. You are attending the workshop entitled Spiritual Care for Staff and Residents in the Midst of a Pandemic with Scott Brooks Cope. Before I turn it over to Scott, I want to thank our member theater community for sponsoring this session. Theater. And here is a word from Cedar Community. Thank you, Cedar Community, for all you do for older adults and for your support of this session. I'm excited to be able to introduce Scott Brooks Cope, who is Director of Pastoral Care and an ACPE certified educator with Phoebe Ministries, a longtime Chisholm member ministry. In this year, when we have been affected by the pandemic, we welcome Scott to talk with us about offering spiritual care to older adults in the midst of it. After the presentation, there will be a time for Q&A and discussion. You're welcome to enter your comments and questions in the chat during the presentation. And then we'll have an opportunity to talk more afterwards.
Hello, I'm Scott Brooks Cope. I'm the Director of Pastoral Care at Phoebe Ministries. And I want to today talk about the spiritual care that we have given to our staff and residents in the midst of the pandemic. Phoebe Ministries has been around since 1903, and we're a proud member of Chisholm. In fact, we're a founding member of Chisholm. And so it's a great privilege for me to really be a part of this today. Phoebe consists of 16 different communities in eastern and central Pennsylvania. We have 4 continuing care retirement communities. We have 8 affordable housing communities. We have our own pharmacy with 4 different locations in Pennsylvania, and we serve many other organizations in our area through our pharmacy as well. We also have Pathstones, which is a program that helps people stay in their homes. First of all, our experience at Phoebe. Phoebe, as I said, has 4 continuing care retirement communities. We have 4 full-time chaplains and 3 part-time chaplains who serve in these communities on a regular basis to provide for the spiritual and religious needs of the communities. And as I also mentioned, pastoral care has been an integral part of Phoebe since the very beginning. All of our chaplains have a minimum of 4 units of CPE training and are board certified with the Association of Professional Chaplains, or are moving toward board certification. I serve as the Director of Pastoral Care, and I'm also a certified educator with ACPE for our CPE program. We train 10 to 12 persons a year in our CPE program in both an extended unit and a summer unit each year. And over the years, the more than 20 years of our program, we've trained more than 200 people studying for ministry. We're one of 10 accredited ACPE centers in the country that are primarily in long-term care. So I want to start with what this past year since March 10th has been like. March 10th, we were meeting as a staff for a pastoral care staff meeting, and someone noticed that that morning we had received an email from our Vice President for Healthcare Services stating that as of that day, there would be no more group activities happening in our healthcare centers. There would be no worship happening, and she explicitly said no communion services would be happening. We already had banned clergy from visiting and families from visiting at that point. There would be no chaplain interns in clinical rounds. And then there would, of course, be no hugging or holding hands. We would all practice safe distancing as well as wearing PPE. So, how bad did things get, or have they gotten? Because we're still really in the midst of this crisis. We had to evacuate our entire healthcare center at our Winco campus to our Allentown campus when our staff there became ill from COVID, and one staff person eventually died. We had to almost overnight create 3 COVID units on our Allentown campus, an old unused section of the healthcare center, to care for 39 sick residents, and we brought them to Allentown on our own buses. This all happened after we had asked the National Guard for help, but they were not able at the last minute to help us. Of those 39 that were moved to Allentown, 16 died in the next 2 to 3 weeks after that. 23 were able to recover and move back to Wyncote, and it was a great celebration day when we were able to move them back to that campus. And there was one especially touching reunion between a husband and a wife who, the husband had gotten moved to Allentown. The wife was in assisted living, and to see them come back together was really pretty amazing. But then there was also all of this loss on one campus all at one time. A second outbreak happened a few weeks later at our Phoebe Burks campus in our memory support unit, and 10 residents died there. Most recovered, and one independent living resident died as well. A third outbreak happened in our Allentown on our memory support unit, and 7 persons died there, but most recovered. The fourth outbreak at our Phoebe Richland campus happened this summer, and 22 persons died within 2 weeks, and many staff became ill. Thankfully, again, most persons there have recovered. More recently, with another outbreak on our Allentown campus, we called on the National Guard to come and help with testing and staffing, and they have indeed helped us with that. To date, we've lost nearly 100 residents to COVID over the last 10 months, and the one beloved staff member. For a long time, we weren't able to have memorial services for any of these persons as we normally would, because that would have meant having gatherings and groups, which we are not doing right now. So finally, this fall, we began to use Zoom and other technology to have memorial services, and we have been able to remember the staff person and all of our residents at this point who have passed. But it has left all of us, and I include myself in that, and our staff with high anxiety, a lot of unresolved grief, and just overall, I would say, some numbness to this situation, as it's been a great shock to all of us. Thankfully, we now have 89% of our residents vaccinated, and 43% of our staff as of my recording this today on January 26th. So our response I want to talk about, we have had a daily COVID call by our Vice President for Healthcare Services with all leadership on the phone every morning at 8 o'clock for the past 10 months. Daily reports include new cases of COVID, deaths that have happened, staff testing as it was starting. Also, as COVID red zones are set up, they have had time at the end of the call to talk about their specific needs on those units where they were caring for some of the most sick residents that we have. These calls provided an important source of daily communication so that everybody in our system was in the loop, and the leadership was very non-anxious and very committed to problem solving in any aspect of this crisis that we needed to. I think that went a long way to providing comfort and support to the other leadership who were on the call, and then I think that was passed along as well. So there were all the different disciplines were always on that call. Pastoral care was included as a vital part of the team. but there were materials management issues to deal with, PPE. Our financial folks were on the phone to talk about how we were going to pay for all of this. Of course, nursing and social work and other departments were represented as well. So this has been a real team effort in our response to all of this. Early on, our ethics committee had to meet to deal with difficult ethical issues brought about by the COVID-19 crisis. We're not used to being a trauma-related center, but in this case, when we had so many people so very sick all at the same time, the question arose from our medical director whether it was safe for us to do CPR on residents who were COVID positive, and when they code, was that a safe thing to do? We had to deal with that in an ethical way and in an ethical decision-making process, which still left the decision up to the resident and the family, but strongly encouraged them to seek treatment in a hospital setting if they still wish to receive CPR if their heart should stop or if they stop breathing. Those were very difficult conversations for our staff to have with families and with residents, but became necessary in the midst of this crisis. I was glad and proud that we have a strong and functioning ethics committee that could so quickly deal with issues around that, as well as other issues such as visitation and things like that, especially visitation for those at the end of life. It seemed important to make allowances for that to happen, and we were a part of looking at the importance of that. So we also, another thing we helped with in our response was visitation was facilitated by Zoom. Nurses and social workers did this, as well as chaplains, and we facilitated connecting our residents who were now becoming very isolated and very alone with their families using technology. And that became an important way to help lessen the loneliness that people were feeling. And then we've had some recent reopenings where we began to have groups again or worship services on some of our campuses, only to then again be closed when the county rates went up or when the rates in our own facilities began to rise as well. So it's been a difficult, chaotic, and traumatizing time in so many different ways. Early on, we focused our spiritual care response on the wellness of our staff. We set up wellness calls early on where our staff could call a conference number, and we as chaplains resourced these calls where our staff members could call and simply talk about what was going on in the moment, how they were doing through all of it, and what they needed in terms of support. And we also were able to give some guidance about good self-care during this time, and also provide information about other resources that are available for our staff as well. We instituted what we call Phoebe Dial-A-Prayer, and it's a in-house number that people can call, as well as a number from outside. And every day, one of us as chaplains, we provide a positive message or just a short prayer to help people through the day or in the middle of the night if they are feeling lonely and just want to call and hear a calming, reassuring voice. They can call that number. This is something we had done years ago, but we hadn't done it for years, and it seemed like an important time to bring it back. And it's been really well received by our staff and our residents. We increased chaplains' chats and devotions for our residents and staff. We added on some of our campuses extra devotions, so there were more times of prayer and more times of worship. We are fortunate on 3 of our 4 retirement community campuses to have the Touchtown TV system. On these campuses, we have a dedicated channel on each campus where chaplains can live stream worship from our chapel, or they can record worship ahead of time or other programming such as Bible studies and put them on that channel. And then the times are sent out to the community and people can tune in and watch those services by way of that closed circuit television system. We also began gathering resources for staff support, and we put on our front page of our internal internet website a place that's simply called Pastoral Care Staff Support. And there's a number of resources on that page that people can go to and access, such as the National Suicide Hotline number or the number for our internal EAP program, which provides free counseling to any of our staff members. We also noticed during this past year that our EAP usage is up 17%. And also it actually became easier to use EAP counselors because, as many others, they are not meeting in person with people, but they are instead meeting by Zoom. So staff could call in from anywhere at any time and set up appointments with these professional counselors to get extra support. We really found the most important thing we could keep doing was to check in on staff one-on-one as they were doing their work, or as they needed to pull our chaplains aside just to talk for a little while about what was happening or to cry on someone's shoulder. That seemed to become still the number one way that we were able to support people. Chaplains were working across campuses to support staff and families. For example, when we had to move residents from one campus to another, those two chaplains from those campuses worked together to support staff and families on both of those campuses. We began to have staff meetings every week just to support one another through this time and to talk about strategies for supporting our staff and residents during this time. The difficult thing became when Holy Week came, how do you do communion when you can't really gather in person for communion? So we discovered that you could buy pre-filled communion cups that are hermetically sealed so that you peel back one layer and there's the wafer or the host. You peel back another layer and there's the pre-filled cup of juice. And I bought 1,000 of those and distributed them to all of our chaplains. And so what they would do is to hand out these pre-filled cups ahead of time to anyone who wanted it. And then at whatever certain time on Monday, Thursday, or on Easter Sunday, they would tune in to the closed circuit television worship service. And as the chaplain led the service and got to the communion part, nurses and staff on our units and on the floors helped our residents take communion by using these pre-filled cups. Certainly not the way we would like to be celebrating Holy Week, but it still was meaningful. And the connection, even with the staff who were helping people with this, we got a lot of good feedback about that. So on some of our campuses, we've continued to do communion in that way. And as I mentioned, we use Touchdown TV for in-house services, but also for external programming. Some of our chaplains have gotten very good at finding calming music or nature programs or other concerts. And they've programmed those as well on the in-house television station to give our residents some calming programming, positive, uplifting programming to watch during this time. We were finally able to have the memorial service for a staff person who died. We were able to use Zoom for that service, and it worked very well. The family was able to tune in that way. Several of our staff people, and this was months after the loss had occurred, were able finally to share some of their remembrances about this person and also to share in the grief that everyone was feeling. Over the course of the fall and just before Christmas, we had memorial services on all of our campuses to remember those who had passed in this past year. And again, we used Zoom technology for most of those services. In several instances, we recorded those memorial services and then send out a link to families so that they could watch those services whenever it was convenient for them. One chaplain was especially creative on her campus at setting up a grieving wall where any staff could come and write on that wall what this past year has been like for them, or to remember a favorite resident that they had lost during the year, or to share some of their hope or favorite scripture verse or something like that. So that became a focal point to help that campus remember, but also to move on during this time. We found that critical incident stress debriefing techniques were especially helpful during this time. We were able to use those on the staff wellness calls that we did. We've been able to use these techniques in one-on-one settings with staff. And our hope is, as we move forward, is to do more and more small groups with staff as well. I'll talk about that a little bit later on. So let me talk about this critical incident stress model. This is a method that I had learned and been taught many years ago when I was in chaplaincy in a children's hospital in Jacksonville, Florida. And it was a course specifically designed for pastoral caregivers. And there was a workbook called Pastoral Care Intervention Course Workbook that was put out by the International Critical Incident Stress Foundation. So you could get certified as a critical incident stress debriefer through this organization as a chaplain or as a pastor in a community. And much of this work is done through disaster training organizations at the national level and sometimes at the local level by conferences or conference committees that deal with disaster training. So the method involves urgent and acute psychological support, sometimes thought of as emotional first aid. So the hallmarks of crisis intervention have historically been immediacy, that is, addressing the crisis as close to the time as possible so that there's not a lot of time gone by. This is really important so that, as I said, our one-on-one encounters in the hallway with staff or in the midst of this trauma has been really important. Proximity is important. The intervention is often done with close proximity to the critical incident. For example, when I was in the hospital setting, and if we had had a particularly traumatic case in the emergency room, maybe later that day or maybe the next day, we would gather staff right there, right in the emergency area to talk about what had happened in the traumatic event and how it made them feel and what their lingering questions or thoughts were about that. Expectancy, both the person in distress and the interventionist have the expectation that the intervention will be acute. It will be directed toward the goal of symptom stabilization and reduction and not a cure. And that's really important. We're not talking about long-term therapeutic interventions here. We're talking about, in the short term, just helping someone to become stable, to be able to keep functioning in their family setting, in their work setting as best as possible. Simplicity is another hallmark of critical incident intervention. We deal with relatively concrete, uncomplicated intervention strategies that avoid complex psychotherapy-oriented tactics. So it really does come down to a lot of times like, what happened? And tell me about it. And tell me about what's happening with you and how this is affecting you in the here and now, in this moment. And then giving support for that, giving resources and other places to go to get support if that is needed. And the final hallmark is brevity. The total duration of the intervention is usually short, typically consisting of 1 to 3 contacts. The critical incident stress debriefing program has three goals. One is to lessen the impact of a trauma. Second is to help those involved recover. And that includes those who are caregivers on the front lines, having backup people. So that if we're going to give care to frontline workers who have experienced trauma, ideally we have backup for those persons who are going in to do the critical incident intervention, so that they have people that they can come back and talk to. And then find people who might most need extra help or support. And these might be folks who don't have a lot of other means of support. So a normal session involves a small group talking about their shared experience with help from a trained leader. It sounds like, but should not take the place of therapy. And the group leaders are often counselors or experts in disaster response, or certified by the National Organization for Victim Assistance. Groups that lead CISD are typically members of either NOVA or the National Volunteer Organizations active in disaster. So what defines a critical incident? Or more and more, we might use the language of trauma. Anyone who has experienced a trauma, a suffering, and or a catastrophic event may benefit from critical incident stress debriefing. The author and researcher Joseph A. Davis identifies the following events and situations as critical incidents, all of which may be helped with this type of stress debriefing. Sudden death, in incidents involving children, serious injury, a threat to an individual's physical and or psychological safety and well-being, a distressing situation or event that profoundly changes or disrupts an individual's physical or psychological functioning, an event that calls into question one's beliefs and meaning-making processes. Here are some of the symptoms and reactions that are very common to such a critical incident. Common physical symptoms, because we know trauma is not only a psychological and emotional experience, but we much more now know that trauma also gets lodged in our bodies, and we carry it around in our bodies. And some of these symptoms immediately follow the critical incident, while others surface over time. If these reactions become chronic, individuals may begin to abuse drugs and or alcohol in an effort to cope with the trauma. In our CPE group in the fall portion of our current unit, we read the book, My Grandmother's Hands, Radicalized Trauma and the Pathway to Mending Our Hearts and Bodies. I'm sorry, racialized trauma, not radical trauma, racialized trauma and the Pathway to Mending Our Hearts and Bodies by Resmaa Menakem. And Resmaa Menakem in this book does a good job of talking about how racial trauma for all of us, not only for persons of color, but also for white persons, is a bodily experience. And some of the issues that lead to racial discrimination and systemic racism are so deeply lodged in our bodies that we are not even aware of it, because they get lodged there over much time. And so his book gives many, many pathways to get in touch with the trauma that is in our bodies, and also to begin to recover from it by using various techniques such as relaxation and breathing, which have to go to the deeper places where trauma gets lodged. And then here's a quote that I really love from his book. Sometimes the body couples and compounds this trauma with the energy of other traumatic events. This can cause people to suddenly and completely, though usually temporarily, lose their cool without having any idea why. Remember, to the traumatized body, all threats, current or ancient, individual or collective, real or imagined, are exactly the same. The lizard brain senses danger and commands the body to fight, flee, or to freeze. Trauma is unique to each body. What one person experiences as trauma, another may experience as nothing more than a big challenge. So these reactions to fight, to flee, to freeze, these are primitive reactions that have to do with survival that are in each one of us. So how we address these in our body, how we listen to our own bodies and help other people to listen to their bodies can help quite a bit in overcoming and recovering from trauma. And of course, in our country in this past year, we have not only faced the trauma of the pandemic, we have also faced the pandemic of systemic racism, which has been revealed in new ways and which has confronted us all with deep reflection and a desire to make changes in our society. So reading this book was extremely helpful for our CP group and some of the chaplains who joined in as well. And I highly recommend it to you and groups that you might be working with. So what are the 7 steps of critical incident stress debriefing? Dr. Mitchell explained the concept of CISD and its steps in a 1983 study published in the Journal of Emergency Medical Services titled When Disaster Strikes, the Critical Incident Stress Debriefing Process. And the following 7 steps make up the stress debriefing process as outlined by Mitchell's fellow scholar, Joseph A. Davis. 1, assess the impact of the critical incident on support personnel and survivors. The facilitator makes his or her assessment as the participants introduce themselves and share their initial statements, making note of key information such as individuals' ages, their involvement in the incident. As the discussion continues, the facilitator is better able to make an accurate assessment of each participant. Again, ideally, this is happening in a small group setting, as close in time and proximity to the critical incident or the traumatic event. 2, to identify immediate issues surrounding problems involving safety and security. Through prompts and questioning, the group's facilitator gains a better understanding of individuals' perceived sense of safety and security, which can vanish instantly when sudden tragedy or loss strikes. Of course, in the pandemic, this has become absolutely paramount. How will we stay safe? How will we stay secure as nurses, as CNAs, and as chaplains as we continue to care for people who are highly contagious and sometimes very ill and very much in need of our cares? And then when I go home, how will I keep my family safe as well is a concern for many of our staff people. So assessing that and talking about that early on is really important. Use diffusing to allow for the ventilation of thoughts, emotions, and experiences associated with the event, and provide validation of possible reactions. Having a safe space to talk about a critical event and its aftermath can be incredibly therapeutic in and of itself, as it helps participants process their emotions and come to terms with their trauma. The facilitator should provide a safe, non-judgmental space for reflecting and processing. During this stage, the facilitator validates each person's unique experience and reactions, assuring participants that their responses to the traumatic event are valid and normal. This is what we tried to do on our wellness calls with our staff, is simply give them a place to talk about what's happening, how it's making them feel, and then try to validate those feelings, to letting them know these are normal feelings in a situation like this. And you have support from us as well. 4, to predict future events and reactions in the aftermath of the incident. I wish we could say we're in the aftermath of the pandemic, but of course we're not. And even when I agreed to do this workshop, I was hoping we'd be talking in the past tense, but we're still very much in the midst of this crisis. But to give participants are further supported by being made aware of possible reactions that may surface as the days, weeks, and months progress, including emotional reactions, physical symptoms, and psychological changes. This knowledge empowers trauma survivors to plan for the future. 5, conduct a systematic review of the critical incident and its emotional, cognitive, and physical impact on survivors, and look for maladaptive behaviors or responses to the crisis or the trauma. When observing participants' moods, word choices, perceptions, and thoughts, the facilitator remains alert to any maladaptive behaviors that might inhibit a survivor's ability to recover and cope with physical or psychological reactions. Common maladaptive behaviors include substance abuse, avoidance, withdrawal, and anxiety turning to anger or to hypervigilance. 6, bring closure to the incident and anchor or ground the individual to community resources to initiate the rebuilding process. As stated previously, CISD is not intended to be the survivor's main source of treatment, but only an initial stabilizing treatment. Therefore, it's important that the group participants are educated on other resources available to them. 7, debriefing assists in the reentry process into the community or the workplace. After completing the CISD process, survivors may be better equipped to regain their sense of safety, security, and well-being, allowing them to return to normal life with greater equanimity and reduced stress. As I mentioned, closure is hard right now because we're still very much in the midst of this pandemic, and we are only now beginning to be vaccinated, which I hope is a sign of hope and turning the corner in the future. But some of our staff early on in the crisis would become, well, let's just say they weren't as compassionate as I had hoped when some staff would express their fears of what was going on. And sometimes staff were very afraid to go on units where there were COVID positive residents. Even with full PPE, they were terrified, as many of us were, by this new virus and the effects it was having. So I recalled an episode of MASH, the TV show from the 1970s, which dates me, I know. But some of you also may remember MASH, or maybe you've seen the reruns that are on various channels. And MASH stands for Mobile Army Surgical Hospital. So it's a surgical unit in the middle of the Korean War that operates out of tents and provides surgical stabilization for people who are being injured in the theater of war. And in this medical center, in the middle of war, you see all of the different disciplines working together. You see the surgeons who do the surgery, you see the nurses who assist them, but you also see the medics who bring the wounded in. You see the nursing assistants. You see the people who make the food for the whole community. And you see the chaplain who has a prominent role in being there and giving care to the community as well. His name is Father Mulcahy, and I love him as a character on the show because it shows him as very human and yet very compassionate and very caring. But every once in a while, somebody in the unit begins to freak out. They begin to really have an emotional or a psychological crisis because they are in the middle of an unbelievably difficult situation. And in those episodes of the show, sometimes they call in Sidney Friedman, who is a psychiatrist in the Army. And he comes and he does an assessment. He begins to listen to the person and what they're afraid of or what's going on. And instead of telling them, well, you need to just get back to your job as a soldier, or you need to get back to the front, or that doesn't make any sense, more often than not, he begins to say to the person to normalize their feelings. He'll say, if you weren't afraid in this setting, then I'd really be worried about you. Then you really might have a problem we would need to worry about. But to be nervous, to be afraid in the middle of a war makes a lot of sense. And I began to coach our staff members, especially our leadership, to use the same approach with our staff members at Phoebe, to honor their fears, to listen to their fears, to validate those emotions of stress and anxiety that were coming forward. And then to help them also to empower and find the courage they needed to continue to serve, because their service right now is extremely important for our residents and the people we take care of. I wanted to share with you the outline we used for our Phoebe wellness calls. Again, these were the calls where we set up a conference number and we set up times where staff could call in, and we were available as chaplains to be there during a half-hour period of time. And again, these weren't meant to be long therapeutic sessions as much as they were to give people a time to simply share what was happening. So we made some introductory remarks. We said these calls are meant to give our Phoebe staff a chance to check in with one another and with us as chaplains about how your work is affecting you right now, or how your personal life is being affected right now, to express feelings about that, and to learn about resources that are available to help. This is not a group therapy session, but more of a brief opportunity to diffuse some of the intensity of our feelings and perhaps not take so much of it home. We will not be allowing persons to express work issues and concerns that are better shared with a supervisor. Also, we will request that you keep what you might hear on this call confidential. So then we just ask questions about what's happening with you right now, what's been most difficult for you, what's one thing you can do. So even in the midst of feeling overwhelmed and powerless, we tried to get people to think about what are some things they could take action on and that they could do. So as folks shared, it was really important for us to validate their feelings, to remind everyone that these are not normal times we are living in, and that feelings of anxiety, fear, anger, grief are all normal and to be expected. It's also important to give the message that there is support available, and we mostly listened during these times. We closed the call with teaching about wellness and strategies for self-care for caregivers. I heard a simple formula that seems holistic early on in the pandemic. I think it was on CBS morning show one day. I saw psychologist Susan Vargas, and you can Google her and you can find these 4 M's that she gave for mental health during the pandemic. And I thought they made a lot of sense, and they were also easy to remember. So her 4 M's for mental health during the pandemic are: 1, mindfulness. That is having some form of meditation each day, or simply taking time, maybe several times during the day, for deep cleansing breathing. If a person has a prayer life, to use their prayer life or journaling. But mindfulness also might be watching the news less, or watching something more uplifting or fun more often. So that's mindfulness. It's time out during the day for reflection. Mastery is the 2nd M. Not a word we use a lot, mastery. But for her, it doesn't mean being more productive or more busy. A lot of us tried to do that early on in the pandemic, only to find ourselves even more fatigued by trying to do that. But what she means is spending time with something other than work that you like to do. Examples are playing the guitar, or sewing, or painting, or it could even be as simple as cutting the grass, or more this time of year in Pennsylvania, shoveling the snow, gardening, reading, taking online classes. I talked to a senior today. He found a college that was giving 30 lectures in 30 days. So every day he was listening to another lecture, and he was getting so much out of that. For me, it's my piano and spending time at my piano, where I can get out some of my emotions and my feelings through my music. So I'm not sure what it is for you, but finding something to be to master right now, or to work at more in terms of a skill. Movement is the third M. She talks about just moving in some way or another, taking a walk every day, exercising, or find a YouTube home aerobics video, or dance, or try yoga. Some way to move our bodies is really important, especially when we've been inside so much and so isolated. The fourth M is meaningful engagement. I always have trouble remembering the title of this one, but I like it as well. Meaningful engagement. Even though we're social distancing, or we should say we're physically distancing from one another in our own apartments, our own rooms, our own houses, or staying 6 feet apart and not hugging one another, she says it's so important that we be reaching out to those we love in meaningful ways and engaging with them by phone, by Zoom, by FaceTime, whatever way we need to. With my 23-year-old sons, one of whom is in Korea right now teaching English, sometimes it's as simple as a text now and then, just to say, hey, thinking about you. Are you okay? What's happening with you? To give and receive love and care can take many different forms during this difficult time. So I like those, the 4 M's of mental health. And then the final thing we would do on the call is we would let them know about resources that are available. Our current plans are to continue to support our residents of our communities through a time that has been very isolating for them. Very often, our chaplains, our chaplain interns provide community that people just don't have during this time, because families have not been allowed to come in and visit them for such a long period of time. People in our assisted living centers who are used to eating in communal dining rooms are not able to do that right now. So our focus has been on how to provide support that can help them to overcome that isolation. We're also intent on providing staff support through ongoing, and even after we get through this, if and when we do, providing support after the trauma of all of this. And one of our staff chaplains came up with the idea of the OASIS model. And we even put this into a grant proposal for the Luce Foundation. Unfortunately, we weren't chosen. So now I'm looking for other ways that maybe we can fund this. But her idea was to provide physical oasis, spiritual and emotional oasis, and then a learning oasis. The physical oasis is to really provide space on each one of our campuses where nurses and staff can take time out, get away from the stress, maybe have recliners there that have massage and heat built into them so that people could really take time out from the stress, even in short periods of time. And then we wanted to provide increased per diem chaplain hours and have chaplains whose only focus will be staff support, and maybe have them on each campus like 4 hours a day, like at least once or twice a week, so that they would make rounds and see how our staff are doing and provide extra support. And then she finally wanted to create a learning oasis on each campus, which would be an actual library of resources that people could go to take out books or to find pamphlets or to connect with other resources that they might need. We want to facilitate remembering. I don't know if you caught it the night before the inauguration last week. There was a brief memorial service in Washington, D.C. It only lasted maybe 15 or 20 minutes. It was very quiet. Nobody said a whole lot of words. There were some really wonderful prayers, especially by the new Archbishop of Washington, D.C. But the one thing our new president, Joseph Biden, said is, we can't heal unless we remember. And then he and our new vice president were very quiet, but turned toward the reflecting pool in front of the Lincoln Memorial as 400 lights were lit all along that reflecting pool, each light representing 1,000 people, 400,000 people that we have lost. And then there was just a time for silence. I think he's absolutely right. I think we can't heal unless we remember. And so the challenge for us now is how to remember the people we've lost, how to remember how difficult this has been, and yet also to remember and to find our resilience and how we overcome difficult times together as a community. So starting in-person groups and worship as it is safe will help us to do that, while also continuing to use Zoom, phone, touchdown TV, whatever technology we can. And we have a current CPE group of 5 chaplain interns who are helping us to give extra support to our residents and staff during this time, especially when other pastors and priests are not able to come in and visit. And we're planning for our summer CPE group as well. And so no matter what's happening at Phoebe this summer, we will be having a CPE group of 5 professionals in training who will be with us to help support and to give extra support to our staff and our residents, but also to learn in a very difficult time how to do pastoral care. And then finally, we continue to assist with structured family visits as they are allowed, and to try to reconnect our residents with their families. So those are our current plans. Here are some of the resources that we have found helpful as a staff. Leading Age has a lot of really good webinars on how to give emotional, psychological support to residents and staff during this time. The Association of Professional Chaplains website has a number of good webinars as well. The Critical Incident Stress Foundation website would be a great place to go to look for resources around how to provide this kind of critical incident stress debriefing and intervention and support. And then here's 2 books that I have found especially helpful. I already mentioned My Grandmother's Hands by Menachem, but the Trauma Stewardship book by Laura Vandernoot Lipsky and Connie Burke is the current book we're reading in our CPE group and with our staff. And she talks about, and the subtitle says it all, an everyday guide to caring for self while caring for others. So she gives a lot of good information to frontline caregivers about how to take care of yourself as you do this difficult work of supporting others through their fears, anxiety, their losses. And anytime we do that, we take some of that on ourselves, but how to not make it our own path, but let it be the path of the one who is suffering that we are trying to walk alongside. So anyway, this has been a difficult time, but also a time of resilience and a time of learning so much, and learning especially the importance of community and being together. So I'm glad I could present this to you today. I look forward to your questions on the day when this is actually presented. And if you have any questions for me or want to reach out to me, here's my information, and feel free to reach out as you want to or need to. Blessings to you and all of your work, and to our many other CHISM organizations around the country who are doing such good and amazing work during this time.